All right, welcome back to the broadcast. Of course, thank you so much for staying with us. Tonight, we are talking about bipolar disorder. Our guests are already in studio. We have Memphis Commander, a clinical psychologist at Mathare National Hospital. We also have Dr. Musheru Wangombe, that is a consultant psychiatrist. We will be getting deeper into bipolar disorder in itself later on, but I want us to first of all just understand the concept of mental health in general. Now, since its inception in 1949, now, Mental Health Awareness Month has served as a beacon of hope to educate and shedding light in the complexities of mental illness and the journey towards wellness. Now, let's talk about mental health definition. What is mental health? According to the World Health Organization, Nick, if we can have that, mental health is a state of well-being that enables people to cope with the stresses of life, realize the abilities, learn well and work well, and contribute to their community. It is an integral component of health and well-being that underpins our individual and collective abilities to make decisions, build relationships, and shape the world we live in. Now, with that simple definition, I guess I'll start with you, Doc. How can communities now just practically implement measures to support mental well-being of one another in the community?
Thank you, Anne, for that question. First is to define what is wellness. Mental wellness is a collection of healthy habits that we need to practice every day to ensure that we are not in survival mode. We are thriving. So we need to learn how to thrive. And good mental health, as you have described, is something we need for ourselves. Good mental health is described as the ability to love oneself, the ability to love others and form lasting relationships, the ability to take disappointments with stride, and the ability to overcome life stresses and contribute to our communities effectively. Yes.
Musheru, how can we, Memphis, how can we really just ensure that at a community level we are protecting one another's mental health?
Thank you, Anne. Just to add on what Dr. Ari has said, when it comes to community level, we need to be able to have effective communication, even from family level, from family levels. And what I mean is, if you have anyone who is going through any form of issue, then just as Dr. Ari has said, we need to come together to be able to support them, so that we are not segregating them with whatever situation that they are facing. So for us being able to work as a family, for example, where families are disorganized or where families are dysfunctional, us being able to work together and just being able to support one of us that is going through an issue, then in that way we can be able to support one another and also engage in support groups. And these support groups could be church, could be just where you're able to get your chama or something like that. So that is able to help us at that community level.
All right. Now, how do we know that one of us is actually suffering from a mental disorder? How do we identify? Because in Kenya, we don't talk much about mental illness. So how do we identify that my sister, my brother is actually suffering? Dr.
Yes, we have various warning signs that we should raise awareness about. And each of us should be able to identify people who are struggling with sleep. Either they're struggling to fall asleep, maintain their sleep, so they have interrupted sleep, or they're waking up in the wee hours of the night, or somebody who is sleeping too much. So one of the warning signs is a disruption in the sleep pattern. So either sleeping too much or sleeping too little. Changes in appetite. Eating too little, eating too much can be a danger sign of mental illness. problems thinking, so that you find you have trouble concentrating, you have trouble remembering people's names or remembering dates, or you spoke to someone on phone, you were supposed to do this, you can't do it anymore. Then we have situations where you have heightened sensitivity. So we have 5 senses: sight, smell, taste, feel, touch, hearing, and people have heightened sensitivity in some mental illnesses, what we call hallucinations. The other thing is people become overly suspicious of others. So we might find people are getting a bit paranoid. Then in addition to that, you may find people have depressed mood, they have low mood. Ideally, we are supposed to be happy when, like for example, you wake up, you're on the right side of your bed, you're happy. Something happens which disappoints you, you become unhappy. But sometimes the degree of unhappiness is so much that this person is not able to lift back to the original setting where they were happy. So they're not able to control their emotions. So what we're trying to say is, warning signs tell us this person either has a problem with regulating their emotions, their thoughts. We diagnose that from the fact that probably when they talk, there might be some irrelevancies in the speech, and bizarre behavior or abnormal behavior. So those are the things we should look out for ourselves and those around us. So even for family members, we should be looking out for each other. But we are not saying if you have a problem with sleep, or if you have a problem with increased sensitivity, or you're getting excessively angry, that you've been diagnosed with a certain mental illness, you need a formal evaluation for you to then know what exactly could be going on. But the warning signs, the earlier you detect them, the earlier you seek treatment, or the earlier you have them addressed, the better for our health.
All right, Doctor, you'll tell us more about now which mental disorder relates to which type of mood. Memphis, I'll be coming back to you later as your microphone is being ikitengenezwa. Now let's just take a look at the Kenya Mental Health Policy, that is 2015 to 2030. Now this policy provides for a framework on interventions for securing mental health systems in Kenya. It also just realizes this is in line with the Constitution of Kenya 2010, Vision 2030, and the global commitments. This policy seeks to address the systemic challenges, emerging trends, and mitigate the burden of mental health problems and disorders. Now, the policy also recognizes that it is the responsibility of every person in the public and private sector to ensure the goal is attained. Now, Daktari, this mental health policy, 2015 to 2030, do you think it's achievable?
Yes, indeed.
And have we made strides to really just get to that level where we achieve everything in this mentioned in this policy?
Okay. We are on the right track, in addition to the fact that there's a mental health task force that came up with recommendations. And the 15 recommendations that they came up with, most of them, we are on track. So the policy is just a guide to show us how to implement some of these task force recommendations. And I would really say that we are on course. And as we increase awareness about mental health, there is the issue of a national mental health survey, which we would like to achieve by the year 2030, so that we're able to have our own statistics. At the moment, we refer to statistics from other countries. We need a national survey to ensure that we get our own statistics and we are able to implement change, even policy changes from that, from the survey itself. So I would still say we are on the right course, and we need teamwork, we need a multi-sectoral approach to ensure that we indeed achieve all that the policy has recommended for us.
Memphis, you are at the ground level. How are we doing as a country in terms of implementing this policy right here?
I would agree with Dr. that we are actually on the right track. Let me talk from my perspective of being a clinical psychologist.
Right.
We did not have psychologists employed by government, but now we have. At least not where we are supposed to be, but at least we have, and it's taking strides to that level. So being able to employ and recognize that there is need for these kinds of personnel to be able to work in the mental health realm, I think that is a good thing. And we hope that as we go forward, probably those financial and not financial kind of just allocating finances towards the mental health and just towards the well-being of the mental health people, that is going to be something that is going to be helping us. But for now, I can say we are on the right track from where we were versus where we are.
All right.
Yeah.
May is Mental Health Awareness Month. Let's just remind our viewers about that. Now, it's also important we just take a look at the importance of Mental Health Awareness Month. Of course, it helps people recognize the ways mental illness impacts their lives. It also educates people about available services and highlights ways to advocate for mental wellness. Even if you do not suffer from any mental disorder, it also creates a time and space to start a conversation around mental well-being. It can reduce the misconceptions and stigma, and can also encourage those who are suffering to seek help and find a support network. Now, Memphis, there are a lot of misconceptions, of course, and stigma revolving around mental health. Tell us, how, when you're dealing with a mental disorder patient, what do you take them through?
Let me first start with that mental health or mental disordered person coming to the hospital. The first, I think we have this traditional in our cultures that probably the first thing that somebody will tell you is that they first took them for prayers. And then when they took them for prayers, it didn't work. That is the time they thought now they want to come to hospital. And when these people come to the hospital, when they come to the hospital at first, they are not in a position to be psychoeducated or to go through psychotherapy, the one that we do. And so the first response is going to be for daktari, that is for medication. So once they have taken medication and they are stabilized, that is the time now they come for psychotherapy. So that is when now psychotherapy comes in. And in psychotherapy, there are several interventions that we do, from the individual therapies to the group therapies to the family therapies, because we have to educate the families on how to be able to support this person, and also how to just take care of this person while they are with them at home. So that way, that is at least a snapshot of what we do for these patients when they come.
All right, Dr. The misconceptions and stigma surrounding mental well-being. When your patients come to you, what is their first step? What do you take them to?
Okay. First and foremost is to take a history. A mental health consultation is just like any other consultation, just like somebody consulting a doctor for cough, diarrhea, flu. So we take a history. We then take them through examination, both physical examination and mental status evaluation, after which we recommend tests. The tests could be blood tests, they could be urine tests, they could be stool tests, they could be imaging, to make sure that we rule out any medical causes of the mental health symptoms that they're presenting with. So when we talk about a mental illness, the diagnosis is clinical. So you take a history, you get to examine the patient, to get to know what signs of the disorder they're presenting with. So there is no specific lab test or imaging or X-ray or CT scan or magnetic resonance imaging, MRI, that will tell you you have bipolar mood disorder. So that is one of the challenges we have, because the mind is not something you can touch. So then most of our patients present with symptoms, but once you send the person to the lab results are all normal, fortunately. And you tell the person your lab results are normal, and they're terribly disappointed. What do you mean? I'm really suffering. But we explain to them, it doesn't mean that you do not have a problem. It's only that your problem is not physical. It has to do with probably neurotransmitters, some chemicals in the brain that they influence the way we think, the way we behave, and the way we regulate our emotions. So then now from getting a diagnosis, then now we plan treatment. Treatment does not mean a prescription of medication. No. It can mean what my colleague has just said, talk therapy. Besides talk therapy, it can mean dance therapy, it can mean art therapy, it could be group therapy, it could be family therapy, the different types of therapy that help us to achieve a common goal. Now, some patients may need medication, and those patients now are the ones who will walk out with a prescription. But the most challenging part of mental health is that of especially starting the conversation, even at a family level. How do you tell somebody that it is time to go and see a psychiatrist? I mean, first they don't take it very kindly, that they think of the worst, that you think they're psychotic, that they have lost it. Well, in fact, they might just be anxious, or they might just be depressed, or they might just be struggling with something. They're just going through life changes, and they're unable to cope. And the fact that they've been unable to cope does not make them seriously mentally ill, which is what most myths will say, that for you to see a psychiatrist, you must probably be behaving abnormally, you must be talking to yourself, you must be laughing alone.
Talking to yourself too?
Yes. But this is not really just self-talk. It's a situation where probably you're hearing voices. Remember I talked about heightened sensitivity? And you're responding to these voices. And these voices are in clear consciousness. You're wide awake. You're not dreaming. Yes. And as I said, the fact that you have found that you're engaging in self-talk, you need to talk to somebody to find out exactly what could be going wrong, not to say that now you have become a patient because of just that one symptom. So that conversation, you need to handle it with care. You have to approach this with tact, because the person's natural reaction would be like, but I'm not sick, which they may have a point. They are not physically sick. There is no wound. They are not bleeding. They are not coughing. They don't have any loose stools. So what do you mean I'm sick? But the way you're behaving, you might need to talk to somebody. So that conversation, even speaking from a family point of view, trying to get somebody to get help sometimes requires some tact, and you need to be empathetic. You also need to avoid judging the person or using phrases like, you're responsible for it, you can snap out of it. I mean, you can man up, or you have to man up, or, I mean, you can just get yourself, you can just get yourself out of this situation. And then the worst thing is, sometimes the patients come to us with all good intent. You have said all tests are normal as the doctor, but the way it is taken, now the relatives will now go to the patient. Why are you taking us through trouble? Why are you faking? Then worse is substance use disorders, where people now feel you're just a social misfit, or it's self-induced, including the insurance. They may not pay for your bill because they believe it is a habit that you picked up. And well, it's at will. You can either stop or not. And so to speak, addiction is a brain disease. and it needs treatment. And people don't need to be judged. They need to be treated with compassion.
Right. So what really triggers these mental health illnesses?
It depends on which type of condition, but stressors can be many. And we have what are called entry events. Entry events are good things, like you might get promoted at work. But for you, you doubt your capability to deal with that situation, because stress is defined as a situation where you doubt your capability to deal with a situation, either personally or socially. So then you have been promoted, or you have gotten you got married, and now that becomes a stressor. The opposite is also true. You may lose the job, you might drop out of school, you might be divorced or widowed or something like that. You might lose a family member, and that can also can be a trigger. In addition to that, we are not just talking about the environment. Remember, we are wired, we are genetically wired. So we are related to each other because we are genetically linked. So for example, you have a relative, or in some conditions, you have several relatives who are suffering from a mental disorder, then the risk of you suffering from mental disorder is quite high. What about adverse childhood events? The fact that sometimes you have homes where people are fighting physically, emotionally, people are having tension, sometimes children are neglected, there is physical abuse, you might have a mentally ill relative, you might have somebody who has gone to prison, you might have watched somebody slap the other one. So all those adverse childhood experiences do contribute to mental illness. So I would say it's a combination of risk factors. Mental illnesses are not communicable, so by sitting next to Memphis, she cannot get what I have.
Yeah.
So then what happens is non-communicable diseases, you have risk factors. You don't have causes per se, you have risk factors. So now, because of the risk, including substance use, it can actually trigger an underlying mental illness. Yes.
All right, now let's take a look at this year's theme. It says where to start, and it begs the bigger question that many people are asking: how can we begin the journey towards mental well-being? Memphis, this is this year's theme, 2023.
Yes. Where to start towards your mental well-being? I could say start. Start by prioritizing yourself, listening to yourself. Listening to yourself in a way that you can be able to realize when the body has said, no, I have had enough and I cannot be able to proceed. What Dr. has said, these stressors that are going to stretch so much that you develop mental illness, as she said, there could be an underlying issues, especially if in your family tree there is mental illnesses. So if you realize you are stretching beyond what your stress levels can be able to take in, then it's time to just take a sit back and start reflecting to see what could be happening to me. The symptoms that Dr. talked about, you're starting to lack sleep, so it's time to start listening to your body, listening to what is this telling me. You have altered your routine, for example, of sleeping. You are not taking, you're not taking the meals the way you're supposed to be taking, probably overeating or undereating. You need to start listening to yourself. And one of the things that we dissuade ourselves from, or people from, when we have these discussions, as Dr. said, you will lack sleep today, and you're like, I am having a mental disorder, because that is what they said on TV. So that is not what we are saying. We are just saying you be able to listen to you as the individual first of all, and realize when something may be going wrong. Because believe me, if you listen to yourself, you will know when something is going wrong. You will, for example, know when a homa is coming. You can know when a flu is coming even yesterday. Like, you can be able to tell this. So similar to mental illnesses, you can be able to touch that and say, something is not right. So that is the moment you start. And starting means you start talking to somebody else. Because we said, with mental illnesses, it is not easy for somebody to come out. But you need to talk to somebody so that they can also tell you whether something is actually wrong or not. And if you realize something is wrong, then I think the best could be to seek professional help. Why am I saying this? I am avoiding a situation where you will tell your friend tells the friend, and the friend tells the friend, and this thing comes back to you. So when such a situation occurs, it actually adds to your mental illness, because then you develop another one, like anxiety. Because you had your own issues, and then somebody else provokes the same, so you may develop another one. So what we are saying, just listen to yourself, and when you realize something may not actually be wrong, because maybe you're going through a situation in life, just a small stressor. But we are saying, if you are going through that, have somebody to outlet to. Have somebody you can talk to, so they can actually confirm to you that you are just fine. So if that happens, then that is okay. If they realize also that there is something wrong, it is good to seek professional help. If nothing is wrong, then you're good. But if something is wrong, then it is caught earlier before it advances. So I think that is, to me, what I can see. But
Dr.
you need to start. Thank you.
We just need to start. Dr. Memphis is saying we just need to start. What do you tell us about this year's theme in terms of starting? How do we now get to a point where we're prioritizing our mental well-being?
I would say that where to start is by educating ourselves, educating others about our mental health, because mental health does not mean it does not mean you're unwell. Good mental health means you're functioning optimally. Mental illness or mental disorders means now you need help. So the most important thing is where to start is to educate ourselves. Then let's normalize that conversation of seeking help. Let's normalize the conversation of me talking about my antidepressant. Just like I would talk about the insulin I use for diabetes. So we need to equalize physical health and mental health. And we need to identify the warning signs early enough and seek help. Then for those who are already seeking help, we need support from family, from the schools where they go to, from work, so that we have employee-assisted programs. We need as much as possible, as much support to destigmatize mental illness and to prioritize seeking help early. That is where we should start.
All right. Now let's take a look at the elephant in the room, that is bipolar disorder. And just to tell our viewer what this is, it was formerly called manic depressive illness or manic depression, and it is a mental illness that causes unusual shifts in a person's mood, energy, activity levels, and concentration. Basically, the mood of a person is just not the usual one that we're used to. So what is that one instance that you have dealt with a patient who is in a manic state? How was it for you for the first time when you handled such a patient?
I think just like any other Kenyan, just like any other person or caregiver that probably could be dealing with this, at first it could be quite a challenge. And at that point, when they are coming in at the manic state, as I said, at that point they normally pass through the psychiatric side. That means at that point you may not be able to discuss with them. You cannot be able to have a conversation with them, even to be able to express what is going through, what they are going through. So most of the time at that moment, it could be caregivers that are giving us information. And until this person is stabilized or is at a level where they're able to converse, then you may not be able to have a conversation with them. And I think this is where as caregivers, maybe we could be having challenges because we are trying to really make this person talk or tell us what is going on at that state. There's nothing that they can be able to do. And that is where the misconception comes in of they are violent. But you are the one who is continuing to just make this person keep, say, talking, or just you want them to tell you something or to do something which they cannot be able to do at that moment. So I think at that moment, to me, it is a state where we, as Dr. said, we need to have compassion for this person. They are struggling. They are going through an issue that if you went through it, you may not like it. So that moment is a difficult time for the client and even for us caregivers as the people that are fast responding to them. But we are saying it is easy. When they come to us, sometimes you will find they are very aggressive, but when they come to us, they calm down because they know they are coming to seek to get help. So sometimes you could find them very aggressive with probably the caregivers, but when they come to us, they would be fine. They're actually not now tied, if they were tied, for example. So to some extent, that's a moment that we really need to be compassionate with these people and try to just understand them, though it is not very easy.
Dr. Now, WHO says that 1 in every 8 people globally suffers from bipolar disorder. What is the demographic in Kenya?
We don't have a nationwide survey per se, so we would have to use statistics globally or from other continents. And the lifetime prevalence, that means like the 12-month prevalence, so that if we are talking about somebody who is likely to present with bipolar mood disorder, depending on which type of bipolar, like for example, if it's bipolar 1, then it becomes 0.6%. If it is bipolar 2, it's 0.4% in females and 0.3% in males. What I mean is bipolar 1 mood disorder is, bipolar presents equally for both male and female, but females present more with bipolar 2. Why? Because bipolar 2 is characterized by depression. That is what brings them to hospital. Then they have extremes of happiness, which are not too, they're not as high as those of the bipolar 1. So that's a difference between bipolar 2 and bipolar 1. Bipolar 2, they have hypomanic states. So they may have 4 days of symptoms that somebody who is looking at them, they can quite see the person is overactive, is probably having decreased need for sleep, but they're not at a point, they're not so dysfunctional as to get to be treated, especially as an inpatient. When it comes to mania, you have an expansive, irritable mood, which in addition to that, the patient becomes very distractible, becomes impulsive, they can buy many things, they can spend a lot of money, they can take a lot of risk, risky activities, including driving very fast, among other things. They can spend a lot of money, they can, what they do is irrational. And then in addition to that, they become very grandiose, so they feel more important than they actually are. They have what we call flight of ideas. Flight of ideas means that the symptoms should be at least 7 days. Most of the day, that person is like that, talking a lot, doing many things. They can't sit still. They keep moving from one topic to the other. They do risky things, and they'll do all those goal-directed activities. They will go to the shamba, they will plow. They will do many things, the washing and everything. Then if, for example, those symptoms are so severe that the person needed inpatient care, even 1 day is enough to make that diagnosis. So what we are trying to say is that is bipolar 1. For you to make a diagnosis of bipolar 1, you must have had 1 manic episode in your life. I go back to statistics. When it comes to adult population, about 2 2.6% of the population, if we could use the US studies by
2.9.
Yeah, and then 2.9 for the adolescents.
Right.
Yes, percent. So then the median age for bipolar is usually about 25 years of age. It's unlikely that somebody above 60 years will be having bipolar, a bipolar diagnosis, newly diagnosed, unless it's somebody who has been on treatment for long. So then what happens, there's bipolar 1, which I've said presents with manic episodes. And what is bipolar? Bipolar, we mean two poles. So you're oscillating between extreme happiness and extreme sadness. Then let me clarify this. There are myths that bipolar is just the mood swings that we experience. That is a myth. Because these are extremes of happiness and sadness, which are associated with the other symptoms I talked about. The over-talkativeness, the increased bursting with energy, the impulsiveness, distractibility. So it's a certain number of those symptoms, like at least you have a certain number of them, together with the expansive, irritable mood. That's bipolar 1. Bipolar 2, we've talked about hypomanic episodes and depressed episodes. Hypomania doesn't bring them to hospital. Usually what brings them to hospital is depressive episodes. That's why it's more common in women. Then we have bipolar, which could be secondary to substance use. Somebody has used the substance, for example, cannabis, and is now presenting with extremes of mood. And these extremes of mood, I must emphasize, have caused you dysfunction. Socially, you're not able to function at home or with those around you. Even at work, you're not able to function. And then the other thing is, in addition to dysfunction, then this person can be a danger to themselves. Bringing me to the fact that in addition to striking that conversation of trying to get the person to help, if they have something that may harm them, if it is a gun, you try and make sure, as you call for help, you can call for an ambulance, but as you wait for help, please remove the dangerous items. If it's medication that they may overdose on, because bipolar patients also overdose on, they do attempt suicide. So if they have medication with them, they're impulsive, they can swallow all of them, or quite a number. If it's a knife that is there, you may need to set it aside as you wait for help. But as I said, you should not be judgmental, you should not be trying to blame this person for their presentation. In addition to substance use, you can have bipolar symptoms secondary to a medical condition. So we need to do the tests we said, whether they're blood tests, urine tests, whether it's imaging, to make sure that these symptoms are not related to a general medical condition. Then there is what is called unspecified bipolar. Then there is bipolar of a seasonal pattern, where probably if you're a person who has a certain deadline around the same time of the year, that is when you get the manic episode, because probably you're supposed to submit returns, reports, or the financial year is ending at that time, and that is when your episode comes. Then there is what is called unspecified mood disorder, like somebody who has just become acutely agitated, can't function anymore, and comes to us. So those are the types of bipolar and related disorders. There is usually revision of the classification every so often. Like for us, we use the Diagnostic Statistical Manual for Mental Diseases. It's called DSM. We are in version 5, text revised right now. It's done by the American Psychiatric Association. And they don't do it on their own. They also involve psychiatrists worldwide, so that there are even some technical working groups, so that we also take cognizance of the various things like culture. Because what is considered normal in our culture may not be considered normal in another culture, but it doesn't mean that the person is unwell. So it's a worldwide kind of consultative forum where for the diagnosis to be made, people have to sit and agree, and they keep revising the texts. And then now there is the classification done by World Health Organization, WHO, which is ICD-11, International Classification for Diseases, version 11. Yes, please.
All right, now we're almost winding up, but Memphis, how do you control now burnout as a caregiver, especially dealing with bipolar? We have a lot of mental disorders, and I've realized that bipolar is not really talked much about. How do you control burnout?
Burnout as a caregiver to bipolar patients, that is, I'm talking from the professional point of view. I think being able to work in a multi-sectoral, in a multidisciplinary environment helps that a lot, because you find that you are not just working alone, but you have other colleagues that you're working with, so that if it is beyond you, then there is somebody else who can take up. And we are talking about the psychiatrist, we are talking about the psychiatric nurse, we are talking about even the social worker, just to be able to help in their different disciplines for to help this client, or to even be able to take the burden from one person to the other. So just being able to have that multidisciplinary approach to taking care of these patients, that can be able to help. And also for caregivers out there, they shouldn't feel alone, or they shouldn't wait for the patient to relapse for them to come back. Number one, ensure that they are on medication throughout, because this medication is what is going to be stabilizing them. So when they are stabilized, chances of them relapsing or even overwhelming you are going to be low. Because there's another misconception that we find, especially with bipolar, that they cannot be able to work, they cannot be, that they are always hyper and all that, but that is not a misconception. I could be sitting here and I'm bipolar, but you can't be able to tell that, because they can be able to function, they can hold jobs, they can sit here and give an interview, they can do every function. And one of the things that you can do is to have that medication and be stable. And apart from that, that is where now they come to the psychologist. Because when you are on medication, you need to be aware that, now that is where we psychoeducate them on medical adherence. So with this kind of support, then they can be able to live that normal life. When they are okay, it means as a caregiver, I am not overburdened. But if we let them just relapse or even use substances, okay, maybe it's not the caregiver's problem that they are using. Sometimes it could be for self-medicating. Because of these symptoms that Dr. talked about, sometimes people with mental illnesses could self-medicate using these substances. And so that is one of the things that we dissuade. So if they are stable using the medication that they have been given and they are adhering to psychotherapy that we take them through, then I think that is going to be lighter on the client and also on ourselves as the caregivers. Yeah.
For the interest of time, I know this conversation is very interesting, and of course we're learning so much. So just in 1 minute, Doctor, your parting shot, especially in this bipolar disorder, I mentioned earlier that it's not talked much about, and you also mentioned something very interesting, that females are the most affected at 3.3%, and the males are coming in at 2.6%. So even as you give us your parting shot in just 1 minute, tell us, why are women the most affected by bipolar?
Maybe I need to clarify that a bit. Bipolar 1 mood disorder is equal proportion. Now, bipolar 2 mood disorder may be more common in women because of depression. Depression is more common in women. And when it comes to the risk factors, in addition to age, in addition to socioeconomic status, because bipolar will affect people with higher socioeconomic status. And then in addition to that, yes, we will find that some of the risk factors are dependent on the specific person, because if you talk about patients with higher genetic loading, like if you have, we'll talk about 60% of the patients with bipolar, they have relatives who, one or two, who have been diagnosed with mental disorders. It could be bipolar, it could be schizophrenia. Then in addition to that, there are what are called comorbidities, so that patients with bipolar mood disorder can present with post-traumatic stress disorder. They could present with impulse control disorders like attention deficit hyperactivity disorder, conduct disorder, oppositional defiant disorder. In addition to that, you will find that those patients have other problems like substance use, we have said. So I wouldn't really say that being female predisposes you to being bipolar. No, it's equal, both male, female. Only that now bipolar too, we have more of the females. And suicide is common for all of them.
All right. Thank you so much, ladies, for making time for us tonight. I understand that this conversation is so wide, this topic is so wide, and there's a lot that we haven't really talked much about, but we are looking forward to really handling it just outside. But remember, this year's theme is where to start. They have said, just start. That brings us to the end of this conversation tonight. To the point concludes at this particular moment. My name is Anne Odida. Thank you so much for being here. Do have a wonderful night and see you next time.